Today's talk really is about the practical application of dietary advice, and that what I'm not going to do tonight is talk about lots of evidence and the reasons why we need to improve our advice in terms of why we do this. This is more how to do it than why to do it. Okay, so what I've been doing in Ireland is I'm a GP and a GP trainer in Dublin, and I have been practicing introducing nutrition into my consultations for about 6 years. I've been involved with Plant-Based Doctors Ireland and also involved with Irish Doctors for the Environment. So I've got a sort of planetary hat as well as a nutrition hat. And what I really want to do today is give that sort of practical advice, what I have distilled down in terms of my practice over the last 6 years or so. So briefly, I'm going to briefly run through some of the context, as in, why are we talking about this? Okay, a lot of us will know this, but just to give us the context, gives us a good base to start on. Then we're going to run through, we might know the information, but why don't we do it? So just discussing what stops us from actively practicing this. Then we got what I call the 3-minute process. Okay, and I've thought of this more because I want to try and sell this, that it is easy to do. We could call it a 3-minute process or a 3-step process. And then I'm going to show you the application of that with cases from my practice, and then run through some brief resources. So first of all, in terms of the context, chronic disease. We know that chronic disease makes up most of our healthcare costs. It's what we see most in practice. And if we look at the graph there on the right, we'll see that in terms of mortality rates in Europe in 2016, 3/4 of these are chronic diseases. So it's cardiovascular disease and cancer, respiratory disease. And if we think back, even say a century ago, it would be a totally different picture. It would be mainly infectious diseases. It would be tuberculosis, diphtheria, pneumonia. And what has helped us change that is probably looking at the cause, looking where did these diseases come from. So when we looked at infectious diseases, we thought, well, maybe it's from germs. We used antibiotics. We improved sanitation. We improved with vaccinations. So we went to the cause of the problem. And now if we look at where our chronic diseases come from, the EPIC Potsdam cohort showed us that there's probably 4 lifestyle factors that are seen to be the cause of 80% of our chronic diseases. And that is smoking, not exercising, being overweight, and diet. So if we could change those 4 lifestyle factors, if we got to the cause of the chronic disease, we could change the outcome. And then if we look at the Global Burden of Disease study, we've realized that if this is the largest study on risk factors for disease, and we found that up at the top is diet, probably along with smoking, but diet is the biggest risk factor, not just for mortality, but also for disability. So what is it in our diet that we need to change? So if we look at the Global Burden of Disease study, this is from the Lancet in 2012. If we look at the dietary risk factors, we'll see the number of deaths that would be that is provoked by certain dietary changes. All the ones on the left that are low, other than physical activity down the bottom, but all the ones that are low, fruit, veg, whole grains, nuts, seeds, these are all plants. So there is a message, we need to increase plants. There is a gain from changing meat and processed meat, but there's a huge gain from changing the plants. And if we look at the most recent global burden of disease graphs from ischemic heart disease in 195 countries, that was just published in October, it's similar again. If we look at what are the criteria, it's the low plants on the left, all your low on the left, fruits, veg, whole grains, nuts, seeds, even fiber, polyunsaturated fatty acids, legumes. It's all the low intake of plants that is a big issue. And then if we come to the EATLancet reference diet, this was released in 2019, 2-year study, 37 academics from across different specialties who managed to take a look at what would be the most optimal diet that we could have to maintain a healthy planet and a healthy population on that planet. And the interesting decision with their reference diet is this graph here. So if we look in the middle, we see this line down the middle at 100 is what we're aiming for. On the left, we've got all the groups of food, and all the different colors are different parts of the world. So the bottom two of each group is sort of Europe, US, similar lifestyles to what we'd lead. So if we look at those, what we're aiming towards is the 100%. But if we look, we're overshooting at the top of the graph in terms of animal products and starchy vegetables. But the message again down the bottom is nobody is getting enough plants. It doesn't matter whether it's fruit, veg, legumes, whole grains, nuts. But most people are uncomfortable about the message from the top of that graph. I'd have to change eating the way I'm used to eating. And we miss the message that we need to increase by at least 50% all the plants down the bottom. So we have a message. We know that there is an issue, but whose job is it? Who's meant to do this? So I suppose there could be an element of policy change in government, or is this a public health issue? And if we look at healthcare, I'd probably say public health tends to have a role looking at general populations. Or then they got the hospital specialists who sit and deal with the chronic disease in the hospital. So they tend to meet them at the end stage. But I'm a little biased, but I think the person in the middle, the community healthcare worker, the family doctor, they have a very important role. And the reason they have an important role is a family doctor, in Ireland anyway, follows patients from cradle to grave. They have this long-term relationship. They have this strong level of trust. And we would find on studies have shown in polls that 80% of patients look to their doctor for nutritional advice. And I'm not sure how doctors, how they feel, how comfortable they feel with that advice, that presumption that patients are looking for advice in their nutrition. Are we comfortable with that? So the other thing with a family doctor is we get great penetration. We cover the whole population anywhere in the country. And we see whether it's independent of religion or socioeconomic status. So we meet everybody, and we meet them when they're well and they're sick. So we've got great opportunity for encouraging behavior change. So why don't we do it? Well, there's several barriers that I'd think of. Like the first is knowledge. Most of us don't have this as part of our training. We don't have detailed information of the power of nutrition to heal. We have technical knowledge of the Krebs cycle and how metabolism works, but not the power of nutrition. But then imagine we know it. Sometimes we might have the information, but we feel, well, we're not experts. We should refer to the dietitian because they're an expert in diets and food. But I'm not an expert in relationship counseling. And I do that all the time. When someone comes in and they're distressed, I have to deal with it. I'm not an expert in exercise, but I recommend it for patients with back pain. So I don't need to be an expert to recommend someone to eat more fruit and veg. I can suggest that without expertise. I'm not doing a radical nutrition assessment of the nutritional adequacy of a diet. I'm just encouraging positive change. And then you may wonder, is it your role? So doctors often feel that their role is as a prescriber. That's a unique role. And GPs would have a role as a gatekeeper. So they need to adopt their role is actually lifestyle improvement, behavior change, wellness. It has to be part of their role to start saying nutrition is what I'm meant to discuss with my patients. And then the other barrier is if we don't practice this personally, we're much less likely to share this information. And that studies have shown that obese doctors or doctors who smoke are 70% less likely to tackle those behaviors with their patients. So unless you're practicing it, you're probably not going to sell it to your patients. But the biggest factor that everyone stalls on is time. I've only got 10, maybe 15 minutes with a patient. How am I supposed to squash in nutritional advice? That's what I'm gonna show you how I do this. So first of all, I'm going to tell you what not to do. Okay, so you might say, I know about nutrition, I know it's important, I'm going to ask a question. So I'm going to say, how's your diet? Most of my patients say, pretty good, doc. And that doesn't help at all. It is a waste of time. So vague questions are not useful. Generic questions. Do you eat your fruit and vegetables? Most of your patients will say, oh, yes, doc, because they're trying to keep you happy. They're trying to please you. But then you're forced to say, is that once a month, once a year, 3 times a day? It isn't a useful question. And then the last question, which is a very common among doctors, is the nutrient question. Remember to decrease the fat in your diet. My patients come back to me and they say, but doctor, when I go to the supermarket, I don't buy fat. What do you mean? And the same happens with fiber. Are you eating fiber? Most patients have no idea what that means. So nutrients are not useful. So the way that we would tend to use this in terms of time is with a brief intervention. And brief interventions is something that all doctors do. And they're not even aware they do it. A patient comes in to me and he goes, oh, Dr. Allman, I've lost so much weight because of what you said to me. And I say, what did I say? Because I'm not even sure what I said in that moment, in that context, and it varies each time. So there isn't a generic way to do this. But we've shown, the evidence has shown that brief interventions work for alcohol, smoking, exercise. And even there's a study I've quoted down the bottom, it's a systematic review on the use in terms of nutritional interventions. And one of the things you'll find is they often end up with small changes, and there isn't a standard way of doing it. Okay, so what I want to share is my standard way of doing it, just as my example. So I've called this a 3-minute process, or it could be a 3-step process. And the theory behind it is, if you go back to the EATLancet, I want to reduce certain foods. I want to replace them with better foods. And then I want to just make sure we've got a practical application in their life on how to do it. Okay, sounds like a lot, but let's talk about it further. So when do we do this? The introduction to when you introduce nutrition is the teachable moment. And the teachable moment is the reason the patient is there. They're scared. They have a symptom. They have a risk factor. They may have a disease. They mightn't like their medication. So any of these are moments that you're able to enter in and think of a nutritional connection to that teachable moment. So the first step is what I would call tailoring the message to a shock factor. Okay, so you have to make it relevant to their diet. And I'll discuss that in the next slide. The second step is the positive suggestion. We don't like negativity. If you just spend the day saying stop smoking and exercise more and get off the couch, that turns people off. So you want to come in with the positive suggestion. Much easier to receive that. And that's the positive replacement. And the third is one meal mastery. So one meal mastery is my way of doing a very quick dietary pattern assessment. This will become clearer when we run through the cases. But if we just first of all think of the shock factor. So the shock factor is really to do with cognitive dissonance. Okay, that's a big term, and it really means someone's unaware of what's wrong. They have no awareness. They're just blindly carrying on. And for an example, Brian Wansink, a social scientist in the States, he's done studies showing that the average person makes 200 food choices a day, and 90% of them are unconscious. So most of us are habitually, blindly following the routine and automatic habit. We don't know what we're eating or why we're eating it. We're just eating. So the shock factor is giving them a piece of information that makes something in their diet relevant. It makes it conscious. You're bringing it into awareness. Then I'll usually give them a question, and the question is really to personalize it for them, to increase that curiosity, and maybe to sit with that, to sit with the discomfort. So let's give you an example. Okay, so these are examples from my practice. So the first case I got here is 45-year-old man. He comes into me and he's concerned about his risk for colon cancer. He's got a friend who had esophageal cancer recently, and it made him much more conscious of his health. And he read in the newspaper that there's a screening test for colon cancer, a colonoscopy, and he can get that free in his insurance. So, doctor, could you refer me? I'm not in a rush to refer him. So I'm going to sit there and I'm going to say, wait, what is your risk? He's a family history, but it's a second-degree relative and it's an elderly person, so that's not a risk. He doesn't have any symptoms himself, so he doesn't have an indication for a colonoscopy. But what he does have is a teachable moment. So the teachable moment makes me think, what can I do next? Let's go for a shock factor. So I'll have a piece of information. I'll say, well, do you know that in 2015, the WHO announced that there was a proven cause of colon cancer in your diet? And then a question, do you have any ideas what that might be? And I'll sit there and I'll wait, because maybe they do know. So I don't want to harp on and waste my time. So I'm going to let them give me the answer. They usually don't. So then I'll say, well, they showed that it was processed meat. And I usually explain what that means, because most people don't know what that means, because we don't buy processed meats. We buy bacon, ham, sausage, salami. I'm going to say, would you eat any of those? Would you have a ham sandwich? Making it practical for the patient. And then I might say, and they also found that red meat is a likely cause of colon cancer. And while they're sitting with that discomfort, I'll then move on to my positive suggestion. I'll say, we know of several foods that you can add to your diet that can reduce your risk of colon cancer. Now, to be fiber. Fiber has been found to decrease your risk of colon cancer by 30%. And I'll probably give a little bit of an explanation. I might say, do you know where fiber comes from? That could be the question. And they usually will say brown bread or something vague, but they only think there's one thing or two things in the diet. And I'll say, well, fiber is actually what holds a plant up. So every single plant has fiber, whether it's fruit or veg or nuts or grains, whole grains, or legumes, pulses, they all have fiber. And I might add in a little bit of an explanation to make it more real and colorful for them. I might say, it can be related to the bugs in your gut. The bugs in your gut, they digest fiber that we can't digest, and they make short-chain fatty acids, and they feed the lining of your gut and they heal your bowel. So I've given them a practical, positive explanation on how to do it. And I might say then, to assess how much fiber in his diet, the quickest way I'm going to do that is I'm going to move on to one meal mastery. So what I'm going to say here is I'm going to say one question to assess how he eats. I'm going to say, what do you have for breakfast? Because most of us usually eat a similar breakfast. It's usually standard. So it's a very quick question. What did you have for breakfast today? Or what is your usual breakfast? And we can tell very quickly if they're having processed meats, as in a fry, very common in Ireland anyway, and I can change that because we can link that with this colon cancer. Or we can say you've got refined carbohydrates and white toast with jam or refined cereal. We can raise our game there. And we can say, well, would you try a whole grain oat? Maybe with nuts, maybe with fruit. So I can increase their dietary quality very quickly. I haven't done a full dietary assessment. So just to recap what I've done there, we have a patient who came in with a concern about colon cancer, teachable moment. We give them a piece of information about the link between processed meats and colon cancer. We gave a positive suggestion on what could improve the risk of colon cancer, which is linked to their reason for attendance. And then we've just assessed very quickly what's their dietary pattern to apply that. Okay, so just to clarify that again, we're going to run through a second case. This is a 65-year-old lady I saw recently. I saw that her blood results were a bit off, so I asked her to come in to see me, and she came in worried. She was concerned. She was sitting at the edge of her seat, wanting to know, why did the doctor call me in? And I told her that her sugar level was high. Not high enough to be diabetic, but that sort of pre-diabetic level. She's overweight. She's anxious. This is begging for a teachable moment. If I'm going to get into the risk factors for diabetes, I have to discuss nutrition. So I've got my shock factor. I got a question for her, or a fact. I'm going to say, European study in 2017, looking at the foods most associated with the development of diabetes. Do you know what the number one food was? And the patients all say sugar, and you say no, processed meats. And then you explain what processed meats are, and you ask, would you eat a ham sandwich? And then while they're sitting with that shock, I'll say that the second most common food was red meats, along with sugar-sweetened beverages. So I've shocked them into making their diet now relevant to their concern. And then I'm going to move on to their positive substitution. I'd say, do you know that there's foods that decrease the risk of diabetes, such as beans or whole grains? And I might give a little bit of an explanation. I might say beans, and I choose beans intentionally because I know the Irish population usually are low in beans in terms of consumption. I'll say beans decrease the absorption of sugar as you're eating. But they also have a second meal effect. So they'll decrease it for the next meal. So if you want to lower your sugar and keep it steady for the day, you should have beans or pulses some way in your diet. So then I asked them, would you eat beans or pulses? And this lady said, I'd have no idea what to do with beans or pulses. I never used them. So I said, well, would you like, I've got some recipes. My favorite recipes, I got a tomato lentil soup, maybe a chickpea korma. I could give you those. And she was delighted. And I'd quickly move on to the next one, one meal mastery. So checking her dietary pattern quality. I'll ask about breakfast, maybe lunch. But the interesting thing with this lady is she left delighted. She came in anxious, but she left empowered. She was given practical recipes that were going to be related to lowering her risk of developing diabetes. Okay, so just as a last case I want to run through, this case is slightly different, but it's the same idea. I want us to just get an idea for that 3-minute process or the 3-step process. This is a 74-year-old. He's a working class man, okay? He's multiple problems. He's attending something like 5 specialists in the hospital, and he's not an easy patient, okay? In general practice, we call this a heart sink patient. When he comes in, your heart sinks because you don't know how to help. And on this review, his blood pressure is high. It's 150/90. I really would like to bring that down. But he says, I'm not taking any more medications, Dr. Allman. I'm sick and tired of the medications. So what choice do I have? I have a teachable moment. We got high blood pressure. Okay, have I got a shock factor? Well, I could say Robert Vogel has shown that certain foods can affect your arteries. We know that high-fat foods, if we eat, say, Egg McMuffin sausages, the artery tightens within 20 minutes and stays tight for 4 to 6 hours. And that's often related to the saturated fat. So I'd ask the question, do you know where the highest sources of saturated fat are in the Irish diet? They usually won't give much of an answer, but I'll answer that it's meat, butter, cheese, and baked goods. Would you eat much of that? And then I'll move on to the positive suggestion. I'll say, Vogel, the same guy, has done similar studies, but he's found that green leafy vegetables, the nitrates in green leafy vegetables, can open your arteries within 20 minutes and keep them open for 4 to 6 hours. So would you eat many greens? And then I'll go on to the one meal mastery, asking about breakfast. This guy didn't want breakfast. He wasn't interested in breakfast. I've never had breakfast, doctor. I'm not going to have breakfast. I've got the choice of moving on to lunch, converting his ham sandwich, but I decided to give him something very specific in terms of one meal mastery. To raise his game, I chanced my arm and said, would you consider a green smoothie? And he's like, well, what's a green smoothie? This is a 74-year-old working class man. So I said, well, a green smoothie is just a handful of spinach. You put in some water in the blender. You put in a half a banana frozen because it's nice or cold. You put in some frozen berries, handful of linseed. You blend it up and you drink it. And I scribbled that down on a yellow Post-it, give it to him. I was a bit dubious that he was going to be able to do this, but he seemed positive. He got what he wanted. He didn't want medication, but I wanted to raise his game in nutrition. So I sent him off. So when I review them, I'll usually review them 3 to 6 weeks. So for example, that patient came back and I'll clarify, I'll usually check things like blood pressure, BMI. I might do blood tests. But say with that patient, I checked his blood pressure. It was a little bit better. But the most important thing is he was doing it. He was actually making green smoothies 2 to 3 days a week. He was also feeling better. And not just in a general way, he was sleeping better. He had less pain. He felt he was able to walk better. Things that I wasn't meaning to do. So these were sort of the side effects of the intervention. So that allowed me encourage him to do more. This is a heart sink patient who comes back to me and says, what else can I add into my smoothie? And that is a fantastic consultation as a doctor who used to be irritated by the same patient. So I'll often add in something else. Maybe we could add in some cinnamon. We could add in some ground seeds, something else to raise his game in terms of the consumption of plants in his diet. And I'll often think of ways to maybe enhance the motivation. I might say, you're doing very well for your health, but do you know that this is an optimal way of eating for the planet? So anything that can maintain it, because the difficulty with maintaining a dietary change is making it sustainable. And to make it sustainable, you have to make it tasty, they have to enjoy it, and you have to maintain their motivation. The stronger their motivation, the more likely they'll maintain this. So what resources might I give? I suppose people all want resources. They think there's this sort of silver bullet special resource that will convert everyone. But if we had that, we'd have the special resource that stops everyone smoking or makes everyone exercise. There isn't a resource. In a way, there is the astute doctor who understands the power of their relationship and their enthusiasm to share information and make it applicable. So the patient that comes into me and likes exercising, goes out jogging, I'll give them a podcast related to maybe fiber, if it was related to, say, anything, bowel disease, cardiovascular disease. And if somebody's into cooking, I'll give them a recipe book. The one there on the screen from the Happy Pair is available in all the libraries of Ireland so they can get it for free. The person who likes to lie on the sofa and not do much, I'll give them the documentary on Netflix. Or if they were athletic type, I might say watch Game Changers. If somebody has a specific disease or a specific food interest, I'll often refer them to nutritionfacts.org, where they can see short videos specifically related to their issue. Or one that I've done more and more over time is I have copies of How Not to Die by Michael Greger. I'll open it up on the page or the chapter that's relevant to them. So the lady before it would have been diabetes, and I'll stick in a little post-it and say, read this chapter. Because what we forget is, because of my relationship, and it comes from me, the power of my advice is much stronger. I am shocked at the amount of my patients that still have their yellow post-it recipe or recommendations still stuck in their wallet or their bedside table. And then there's some people whose motivation for change is huge. They don't want to just change one or two things in their diet. Some of them want to change everything. So it may be that they've had a major event, a heart attack, or a patient of mine went into hospital recently and he had chest pain, he had an angiogram, and he was found to have minimal stenosis. So he didn't really need anything. But he was so shocked at how vulnerable he felt that his motivation was huge. And he changed his diet overnight after looking into what was the evidence. So if somebody's ready for a big change, sometimes I'll give them fully plant-based resources. So I might say the Plantrition Project for adults or for kids, about 30 pages. They can get that online. I could send them a PDF of it. Or Forks Over Knives have an introduction to plant-based diet. Healthcare Professionals UK or Physicians Committee for Responsible Medicine, all of these 21-day plant-based challenges. Or if you make it culturally relevant. So Happy Pair are two attractive, athletic, popular in social media twins that have set up this online resource where someone can do a 4-week course to learn how to cook plant-based. And because we've approached them, they give us 50% off for our patients. So we're able to access cheaper online resources for our patients locally, which works out really well for the patients. But mainly, I want us to focus on the positive. So I want us to remember that whatever advice we give to the patient, they are looking for this information. They are empowered by taking charge of their life, by making these changes. And then in terms of the positive, the effect on us as doctors. We have a knock-on effect that the pleasure of seeing your patient getting better, potentially reversing disease, even raising our game by sharing their best recipes. And also, if we go back to the EATLancet report, all these changes are not just for health, they're also for the planet. So there's several aspects to this process. And then, in conclusion, if we look at to remember that nutrition has to be the doctor's role, that a brief intervention can have a powerful effect, that each time they come in, that teachable moment is an opportunity to challenge the status quo in terms of their diet. And then to make the positive replacement, because in nutrition is what do you replace instead of a food? And then the dietary pattern assessment in terms of what do you have for breakfast? And then just keep adding continually on review, because we can keep raising their game. Because in a way, as a doctor, we think about the Hippocratic Oath of do no harm. And we have to advocate for our patients. But that process has now broadened to what do we do to have no harm to the planet as well as our planets, as well as our patients. So, and I think now that probably one of the most powerful things that we can do for both health and the planet is to recommend plant-based dietary changes among our patients. Let us not miss this opportunity. Thank you.
Thank you very much, John. I already got a few messages about this on this great talk, and that people are happy to be here tonight. Yeah, great talk. We'd love to broadcast that to every GP and family doctor around the world. So before we start with Q&A, we have Dr. Sean Owens as well here tonight, and he's working with John Allman as well at the Plant-Based Doctors Ireland, and is working especially on what we see already here, the attitudes on the role of nutrition in primary care and how to implement nutrition in these training programs. So thank you very much, Sean, for being with us and sharing your research and expertise here. Thank you.
Thank you, Nicholas. Can you hear me okay?
Yeah, absolutely.
Well, no, it's a real pleasure to present at PAN. Thank you so much, and thank you, Johnny, for your wonderful talk. I take something from it every time I hear it, because it's so relevant to what I do. I'm a fairly recently qualified GP. I work in a village beside the seaside in the east coast of Ireland, about halfway between Dublin and Belfast. And everything that Johnny just presented is, like I said, very relevant. I think what I wanted to talk about was to bring it into the macro a little bit more. Why is it that you'd have to go to Dr. John Allman to get that advice? Why isn't it every GP surgery? That is, why isn't nutrition on the agenda when it comes to medical training? Because as someone who recently graduated from GP training, I found that it wasn't there. So I wanted to present some original research based on that. But considering it's a Tuesday night, everyone's had a busy day at work, I didn't want to put you through a survey. I wanted to actually bring you more of a personal journey. And this is a bit more of what were the barriers to change? How can we get nutrition onto the agenda in medical training, specifically with respect to general practice here in Ireland? So what are those barriers to change? And I always think that probably the crucial slide in any talk is the disclaimer. And my disclaimer is ABBA. Not that I'm a huge fan, which I am. It's more that they have this opening line of a song that always sings through to me. I'm nothing special. In fact, I'm a bit of a bore, because for the last 4 or 5 years at night, for kicks, I've been reading books on plant-based diets and climate reports from intergovernmental agencies. And my poor wife was wondering what happened to our mid-20s. Where did it all go wrong? And about 4 years ago, this was niche. But thanks to efforts from the Lancet, from Greta Thunberg and David Attenborough, this is now mainstream, and certainly our patients want to know about diets and about how the decisions that we make with them are going to affect the planet. So with that in mind, my real disclaimer is that I'm a part of 2 groups. One is Plant-Based Doctors Ireland, and the other is Irish Doctors for the Environment. But there's no money to declare there. There is an awful lot of reading and sitting up late at night, but I feel that that's really the nub of where healthcare is going in the future. So what I want to talk about, well, before trying to get diet onto the curriculum and into the consultation, I think we need a little bit of hubris and ask, is diet important in Ireland? And if it is, well, what are the barriers to change? Why isn't it on the curriculum already? Why isn't it on the agenda? Then I'll present just very quickly the survey of GP trainees that myself, John Allman and my other colleagues have done. And then we'll talk about next steps. So if you go to the PAN website landing page, you're always hit with this stat that chronic disease is now diet is now the leading cause of chronic disease globally, either undernutrition or overnutrition. So from the Global Burden of Diseases survey, we know that to be true. But what about Ireland? Well, it's grim reading. In terms of our statistics, the leading cause of death is cardiovascular disease, which we know is largely preventable. The national prevalence of diabetes was well underestimated at 6.5%. In fact, it's projected to double by 2050, and already it accounts for about 10% of the health spend. 6 in 10 adults, 1 in 4 children are now overweight or obese. And the World Health Organization says that we're going to top the charts by 2030. Now, Johnny alluded to this earlier. When you ask anyone in Ireland how their diet is, they say it's fabulous, doctor. This is a Eurostat report from 2015 asking Europeans who's got the best diet, and we think we're doing fine. So we don't know that there's a problem. That's the first barrier. And this is the Irish College of General Practitioners curriculum, and it's probably standard for any kind of curriculum or any medical textbook. You've got all of your different pathophysiologies, heart health, respiratory, neurology, sexual health. And this is where the number one driver of chronic disease isn't. So nutrition isn't on the agenda, it isn't on the curriculum. And these, of course, are all the modalities where nutrition is implicit in the pathophysiology, the treatment, the management of what we see every day. So for me, from that vantage point, this is an unmet need. So I've had about 4 or 5 years of autonomous reading, and you should be wary of autonomous reading. And anyone on a PAN website or a webinar, I'm sure has their own nutrition journey. And you'll know this meme on the internet. It's that doctors don't know anything about nutrition. They'll say that I was diabetic, I went keto, I went to my doctor and they fell off their chair because of my cholesterol. Or doctors are given 2 hours of nutrition over their medical school career. Now that was true for me, that was true. I didn't feel I was adequately trained in nutrition. I thought it was an unmet need, but that's a little bit different than, that's not quite a mandate. So I did a quick literature review, and we don't have time to go into it all now, but this is from the Lancet Planetary Health of 2019, a systematic review of nutrition in medical education, specifically undergraduate. And this was looking at medical schools in the US, in the Europe, Middle East, Africa, and Australia. And it said what we thought was true, that this review of nutritional education says that medical students want to know the knowledge, the skills, the confidence to take on chronic disease, but they aren't supported. That training isn't there. So I thought I'm gonna give that training to my colleagues. I was in a small group of about 14 trainees, and we had the opportunity to present each other. So one morning I hit them with everything I had of plant-based diets for heart disease, for diabetes, for cancer prevention, the whole lot. And I had a little survey that went around afterwards. And one of the comments was that it was an evangelistic presentation. And it didn't sit quite right, because I didn't want an evangelistic presentation. I just wanted to give the facts. And I thought once people knew that all of this fantastic data about diet and disease, that everyone would go plant-based, essentially. And I know that was hubris. And it reminded me a little bit of the patients who sit outside a hospital and smoke. Surely they know. Well, they do. But it's a little bit more than that. So I wrote to the college. I said, we have an unmet need. The curriculum was open for suggestions. I said, we need diet on the curriculum. And it was turned down. I then got a new GP trainer who, to my surprise, had a lifetime's work in breaking down barriers and instigating change. And he said, what you're trying to do is a little bit more difficult, because people eat and people have habits for many reasons. We eat to our budget, we eat to our religion sometimes, we eat to culture, we eat to our environment, to our emotions. A 2-hour presentation on the benefits of a plant-based diet isn't really any inflection point. So I realized that we'd have to do a little bit more. And I think 2 texts I think that really inform me going forward weren't plant-based books at all. One is Salt, Sugar, Fat by Michael Moss, showing about how it's not really a level playing field. We might have 15 minutes with our patients every month or 2 months, but the food companies have our eye lines all of the rest of the time. Those 200 unconscious food decisions we make. They know when we're vulnerable, when we're stressed, and they're there with attractively priced, highly processed, highly palatable foods. And the other one was The Hungry Brain by Stefan Guyenet, showing us the neuroendocrine reasons for why we overeat and why we make the food decisions we do and why it's so hard. And that was, that really informed me going forward. So I thought we need data. So myself, Dr. Allman, and my trainer, Dr. Carroll, said, let's get a voice from the GP trainees themselves. So we surveyed them. So that's what I'm just going to show briefly now is the highlights of what Irish GP trainees want. So just as a background, we know that nutrition has a fundamental role in health, leading cause of chronic disease, but we know that the nutritional component of medical education globally is insufficient. We don't know about it in Irish general practice. So let's find out. So there are no validated surveys assessing attitudes to nutrition. There are some that ask about nutritional competence. We don't know whether the trainees or whether the program directors who deliver that training feel that there's adequate nutritional education. So the central question was, is there sufficient nutritional education for GP trainees, according to both the trainees themselves and the program directors? There are 14 training schemes in Ireland, over 500 trainees and about 60 program directors or associated program directors that deliver it. We were granted ethics by the college, and last year a survey went out with a reminder of 2 weeks, a survey monkey. Everything was carried out anonymously. And the data was collected as a Likert scale, so the answers from strongly disagree to agree were given numerical values, and we used a statistical analysis called Tassel and Veerman's measure to find out not only was there agreement, but was there consensus around agreement or disagreement. And the program directors and the trainees were asked the same question: is there sufficient nutritional training available to trainees? And as such, we could do an ANOVA analysis to see if they agreed. So all but one of the training schemes participated. We had over 100 respondents in total, which is really good for a GP trainee survey, because GP trainees get bombarded with these surveys. This is what the results for the trainees looked like. This is what it looked like for the program directors when it's tabulated for statistical analysis. Not that exciting. So I thought I would just show you some of the raw results because they tell a story. And I'll just show you some of the highlights. So when we asked the trainees, is it your job? You know, is this something that you need to be doing to support your patients to follow a healthy diet? They all said yes. So this is on us. When asked, do you know what a healthy diet is? Everyone was pretty confident. Yeah, I know what that is. Now, everyone's probably got their own idea of what a healthy diet is, but everyone was pretty confident. Then it started to fall apart a little bit. I feel confident identifying and managing this. Some agreed, some not so sure. And yeah, we're a little bit at sea because we've had very little training, I believe. Okay, so the driver of chronic disease is diet. Do you take a diet history when talking to your patients about chronic disease? Well, some do, some don't. Only 10% always do, and 10% never. And when asked which diseases do provoke taking a dietary history, of course, heart disease and diabetes, you would kind of expect. But there's a lack of knowledge of the link between diet and arthritis, for example, or COPD or depression. We don't have that association, so we don't ask. And can diseases the 10% of our health spend, diabetes, be reversed in primary care? Well, they all said, yeah, of course. So what is the barrier? They all agreed there are barriers. And we asked what they were. They said, as Johnny alluded to earlier, time. I'm not confident enough. Patient-specific factors, lack of resources. And it's going back to that barriers to change slide. There's any amount of them. So maybe it's not our job at all. Maybe it's the job of a dietitian. They all disagreed when asked, do you have access to a dietitian? For a country of 4 million people, we've less than 100 community dietitians. So if not us, then who? And when asked if medical education to date have been adequate in preparing us to go over the trenches, they all disagreed. We're not ready. And this is an interesting one. Where did you get your knowledge on nutrition from? It wasn't undergraduate or postgraduate, it was personal experience. That guy down in the gym, or online resources. Twitter is an online resource, right? But it wasn't validated. There was no health professional study follow-up. There was no epic Potsdam that Johnny just talked about. It was whatever you're having yourself. And yeah, everyone was interested. They wanted more. So what did the Irish GP trainees say to us? They said that yes, diet is important. Yes, it's our role. Yes, it's the #1 driver of chronic disease. There are barriers, especially access to dietitians. We're not that confident, and we don't ask if it isn't heart disease or type 2 diabetes. And yes, we would like more training. For completeness, we asked this similar set of questions to the program directors. And they also thought that, yeah, it's the job of our trainees to support our patients with a healthy diet. Did they feel that chronic diseases such as type 2 diabetes could be reversed? Yeah, they're a little bit less sure, but yeah. And do they deliver that training? Only one GP training scheme had mandatory training in nutrition. And when asked how many hours of nutrition tuition are given over a 4-year program, the majority said less than 5 hours. So that's our mean. Doctors don't get much training on nutrition. So our program directors told us that yes, diet is important. Yes, it is our rule. There are many barriers, and there is about an hour per year of tuition, and we'd all like more training. And when asked the same question, is there sufficient nutritional training available to trainees? ANOVA analysis showed that they were from the same distribution, so we could say that they agreed in that assertion that nutritional training to date is insufficient. So, summing everything up, our survey said that nutrition is an unmet need in Irish GP training. This is consistent with international evidence. There was agreement and consensus from both trainees and program directors, and more training would be welcomed by both. So we've gone from a meme that doctors don't get enough education. We've got some data, we've done some statistics, we've referred for publication. But I think what we have now is a mandate. And this is something we can bring to the college to say, this isn't just my idea, this is what the trainees are saying. And colleges are very responsive to what trainees say. But we need more than that. That won't be enough. So 2 years ago, myself and some like-minded doctors and dietitians and other healthcare professionals got together and formed Plant-Based Doctors Ireland. We launched at VegFest. We had a conference in the Mater Hospital. It was the most prestigious hospital in Ireland, sold out. So people want to know. It was mostly to GPs. A few months later, we petitioned the college to pass a motion recognizing the planetary health emergency. We put together a continual medical education bid for already qualified GPs. We've collaborated with a new group called Irish Doctors for the Environment, who are far bigger, far better organized than we are. We organized a forum discussion on the EATLancet diet. We had a follow-up conference, February 2020, just before everything closed down. Again, in the Mater Hospital, this time looking at how our diet affects the planet as well as our health. We've had articles, blogs, advocacy, working groups within the college and with Irish Doctors for the Environment. And we've been teaching GP trainees that evangelistic presentation we've given now to many different trainees around the country. This is us at our inaugural conference, 2019, a full conference, and this is us 1 year later, talking about the link between diet and planetary health. And I always come back to this. This isn't a concession, as was alluded to earlier. If it tastes good, it looks good. This isn't a highly scientific, biological medication we're trying to pass. This is good quality food. So just to sum things up, the playing field, as I see it, is that we have a highly toxic, highly processed, stressful, distracted food environment. And we have a limbic system that's also stressed out and distracted. And these two are working in perfect concert. Of course, we're overeating and distracting ourselves and medicating ourselves with junk food. But what the food companies haven't taken into account is the power of the consultation. And Johnny's consultation is different than mine, which is different than yours, because we know the patients from cradle to grave, as alluded to. Calgary, Cambridge, Analytica. We know our patients, but for all the right reasons. We know the ins, we know the hooks, and we know the rubs. So I think that with the appropriate education and with nutrition on the agenda, we can make that inflection point I wanted earlier. So just to acknowledge the co-authors of that paper, Dr. John Allman, Dr. Austin O'Carroll, and the Irish College of GPs, who have been really supportive of planetary health and plant-based diets. They're just a little bit distracted with this thing called COVID at the minute. Irish Doctors of the Environment, again, they're so well organized and they're really, really instigating change. My colleagues in Plant-Based Doctors Ireland, and especially PAN for asking us to come on here tonight. But especially thank all of you, over 100 people here on a Tuesday night to listen to this. So finally, thank Abba, and thank you, Nicholas.